Okay, yeah, we can see them now. Is it advancing on your end?
Yeah, I will go to next slide to see. Is it working?
Yes, it is.
Yeah. Good morning, everyone. My name is Rafi. And I'd like to begin by thanking you all for the opportunity to be here today. I recently completed my training as a hematopathologist. And I am pleased to present on topic of transfusion-associated circulatory overload. I hope you find the presentation informative and engaging. I have no financial disclosure to declare. Today, I will start with some background on why TACO matters, then give an overview where things stand, walk through the key article's main points, discuss how we can use these insights in practice, and finish with a Q&A. TACO has often been underdiagnosed and underreported, highlighting the urgent need for improved recognition and preventive strategies. A growing body of research emphasizes this need. For example, recent articles have addressed different but complementary aspects of TACO. A systematic review and meta-analysis published by Transfusion examined TACO incidence using active surveillance data, underscoring that traditional reporting methods may severely underestimate its true frequency. Meanwhile, a dose-finding study in Fox sanguinis investigated how much furosemide should be given to prevent TACO, suggesting personalized strategies to mitigate risk. Additional contributions from the Blood Journal further explored the diagnostic and therapeutic approaches to the cardiorespiratory complications related to transfusion, including TACO. So, what is TACO? It is a condition that can happen during or up to 12 hours after transfusion. It is usually caused by fluid overload, especially in elderly patients with heart or kidney impairment. TACO is leading cause of transfusion-related death reported to the FDA, and it has happened when too much fluid leads to cardiogenic pulmonary edema. Basically, the heart can't handle the volume and the fluid backs up into the lungs. When we look at the pathophysiology of both TACO and TRALI, we can see in the right panel, this side shows hydrostatic pulmonary edema, which is what we see in TACO. In TACO, the problem comes from giving too much fluid or blood too quickly. This increases the pressure in the lungs capillaries, kind of like water building up behind a dam. The pressure pushes fluid into the air sacs of the lungs, the alveoli, but the walls of the alveoli stay intact. There is no damage. So the fluid that leaks it is mostly water, low in protein, and there is no inflammation, no immune cells, no platelet, and no fibrin. This fluid makes it harder for oxygen to get through, but the good news is it is reversible with diuretics and time. The lungs can clear it out. However, in the left panel, this side shows inflammatory pulmonary edema, like what happens in TRALI. Here, the issue isn't pressure, it is the immune system reacting to something in the transfused blood. This immune response activates neutrophils, which damage the lung capillary wall. Once the barrier is damaged, protein-rich fluid, immune cells, fibrin, and even platelet leaks into the alveoli. So now the lung is full of fluid and inflamed. That's why oxygen exchange becomes severely impaired. This is an cardiogenic pulmonary edema, meaning it is not caused by fluid overload, and unlike TACO, diuretics does not help here. The focus is on supportive care like oxygen and ventilation. So for us to diagnose TACO, and according to revised ISBT, IHN, and ABB TACO case definition from 2018, a diagnosis of TACO requires that patient show at least one key sign, either A, acute or worsening respiratory compromise, or B, acute worsening pulmonary edema within 12 hours of transfusion. Along with total of at least 3 findings from A to E, such as evidence of new cardiovascular changes like hypertension or jugular vein distension. Signs of fluid overload such as positive fluid balance or response to diuretics, or an elevated BMP level more than 1.5 times the pre-transfusion value. Over time, the definition for TACO have become much more standardized. Now the CDC is on the same page using consistent criteria. But the most hospitals still rely on passive surveillance, basically waiting for staff to report cases, and that means a lot of cases go unnoticed. So we need a better way to get the full picture. That's why our first study pulled together data from several active surveillance studies using meta-analysis to see how often TACO usually happens and how those rates differ across different settings by Dr. White. Before we dive in, when we think about the challenges in TACO surveillance and research, a few key issues comes to mind. Most hospitals still rely on passive surveillance, meaning they wait for staff to report reactions. The problem is that often lead to under-reporting, so we end up underestimating the real risk of TACO. Some studies using active surveillance have looked more closely and report TACO rate in different ways, per patient, per unit, or per transfusion episodes. But till now, the data hasn't been pulled together into one clear evidence-based estimate. That's what this study set out to do: combine all the available data through meta-analysis, estimate how often TACO really happens, and see how those numbers vary across different studies. The study design was carried out using systematic review and meta-analysis following the PRISMA guidelines. Medical librarian searched midline and MBase. At first, there were no limit on language or publication type, but later they narrowed down to full text studies only. They exclude anything published before 1990 since TACO wasn't formally recognized yet. They didn't search gray literature due to limited resources. They began with 5,372 articles, removed duplicate, and screened 5,365 titles and abstracts, ruling out 4,898 as not relevant. From the remaining 467 full-text papers, they exclude 446 for reasons like being abstract only or using passive surveillance, and ended up with 21 database studies plus one more found by hand, 22 solid studies in total. Out of the 22 studies, they looked at both about 8 studies covered broad hospital-wide patient group, while 14 studies zoomed in on a specific population like cancer or hematology patients, pediatrics, surgical or ICU cases, and a few others. Around 40% of the research was done prospectively and half were retrospective, with a handful using other approaches. Most of the work, about 70%, have come out since 2015, reflecting the most up-to-date evidence. When it's come to definition, the most frequent definition for CDC, the most frequent definition is CDC NHSN used in 9 studies and the ISPT IHN definition in 5 studies. And almost every study reported risk per patient must also give TACO rate per blood unit, and a few even broke it down to transfusion per transfusion episode. Out of the 22 studies included in the meta-analysis, 9 studies or 41% used prospective cohort design. Almost all studies, 21 out of 22 define TACO using recognized diagnostic criteria. Most of the studies were conducted in the United States, 11 studies, while Canada and Netherlands each contributed 2 studies. In terms of study population, 14 out of 22 studies, 64% focused on specific patient groups. This included 7 studies on surgical or ICU patients, 3 studies on cancer or hematology patients, and 4 studies on pediatric populations. There is a significant variation in study design, patient population, and how TACO rates were measured. Some studies used rigorous definition like CDC or ISPT IHN, while others used descriptive or custom criteria. This variation is part of what makes meta-analysis important. It's helped to pool diverse data and produce more reliable generalized estimates. This chart, known as forest plot, shows data from multiple studies on how often patients develop TACO, with each dot represent a study rate per 1,000 transfused patients. And the horizontal lines show the 95% confidence intervals. The bold estimate at the bottom combines all studies, indicating about 22 cases of TACO for every 1,000 patients who receive any transfusion. If we count by individual units, every 1,000 units transfused carry about 2 cases of TACO. But if we look at each transfused event where a patient might get multiple units, the risk jumps to about 6 cases per 1,000 episodes, since larger and or faster volume transfusions drive up the chance of overload. This chart combines data from 5 studies for RBCs, 4 for plasma, and 8 for platelets into 3 bold TACO rates. For red blood cells, those 5 studies give about 1.3 TACO cases per 1,000 units transfused. The 4 plasma studies show roughly 1.6 cases per 1,000 units. The 8 platelet studies stand out with about 6.3 cases per 1,000 units. In other words, platelets carry the highest per unit risk of circulatory overload. Here we can see units of measurement as we mentioned in the previous slides. In the first column, last column is I2 values, indicates that there is a significant heterogeneity. In this table, they use meta-regression to evaluate the source of heterogeneity, and they found that limited study population was a significant source of heterogeneity, in the pre-patient analysis, positive effect. They also found that prospective study design negative effect and recently of publication year positive effect were significant source of variation in the total units transfused analysis. Today, evidence makes it clear that TACO transfusion-associated circulatory overload is the most common cause of transfusion-related death in the US. So we cannot ignore its risk when deciding to give blood. Randomized trials consistently show there is no benefit to a liberal transfusion approach, which is why we move toward more restrictive thresholds. And that's only safer when we have accurate active surveillance data on TACO rates. In fact, when we compare active monitoring with older passive reporting systems, we see TACO rates that are dozens of times higher, revealing how much under-reporting has occurred. We also now recognize that TACO happens far more than Trali, sometimes 10 or even hundreds of times more. And that incidence varies depending on patient group, study design, and how recently the data were collected. While surveillance and while this meta-analysis is strengthened by its focus on active surveillance and robust statistical methods, we still face challenges like high variability between studies and difficulty pinpointing risk for individual blood products. Moving toward, we need better real-time monitoring, targeted strategies for patients at high risk, and smart decision support tools to help clinicians prevent TACO and keep our transfusion practices as safe as possible. Prevention and management. First, we need to identify the high-risk patients. When assessing a patient for the risk of TACO, we need to ask if they have heart condition like heart failure or severe valve disease. Are they on regular diuretics or have severe anemia? We also consider if they have pulmonary edema or unexplained respiratory symptoms. Next, we check their fluid status, whether they have had IV fluid in the last 24 hours, show sign of fluid overload like peripheral edema, or have conditions like hypoalbuminemia or significant renal impairment. If any risks are identified, we need to carefully review if the transfusion is absolutely necessary and whether it can be safely delayed. If we proceed, we must take action like dosing grid stills by body weight, giving 1 unit at a time with symptoms monitoring, tracking fluid balance, prescribing diuretics if appropriate, and closely monitoring vital signs and oxygen levels. And finally, always remember that babies have different physiology, so TACO risk and dosing must be calculated by weight accordingly. Whenever clinically feasible, prefer single-unit transfusion over multi-unit orders in non-bleeding patients to limit volume exposure. Infuse blood at a slower rate, for example, 1 to 2 ml per kg per hour in high-risk individuals. To reduce cardiac preload stress, use patient blood management strategies such as treating anemia with iron or erythropoietin before transfusing to avoid unnecessary units. After that, we should think of the therapeutical intervention. Diuretics, mainly furosemide, are the cornerstone of TACO prophylaxis. This is an excellent new paper explore how to pick the right IV furosemide dose before a blood transfusion to prevent TACO, using a dose response model that account for weight, kidney function, blood pressure, albumin, and the prior diuretic use, it gives us a data-driven way to tailor diuretic dosing and keep our transfusion safer. Finally, active monitoring and early intervention. When a patient shows a breathing or heart-related distress during a transfusion, stop the blood immediately, verify their identity, disconnect the transfusion while keeping IV access, and promptly or quickly order chest imaging and blood test. Check their oxygen level and cardiac function, and send the blood unit for lab evaluation. Use these findings to distinguish between TRALI, TACO, or other causes. If TACO is likely, give a trial of diuretics, monitor closely, and if their modified early warning score, MEWS, is above 3, a sign they are at a higher risk of serious deterioration based on vital signs like heart rate, blood pressure, and respiratory rates. Consider ICU consultation and ensure the reaction is reported to the blood bank. Here are the references. Thank you for attending today's session, and I am happy to take any questions.
Thank you so much, Rafi. I'll open it up to the audience first to see if anybody has any questions, and then I might have one if no one does.
Hey, Rafi, I just had a quick question for you. So you had mentioned that there was I think 3 criteria that were used in that meta-analysis to assess the occurrence of TACO. Did you go over those criteria to see if there was one that you thought was more sensitive, if it's accurate, more sensitive, more specific, or yeah, which of the criterias that you reviewed did you think was the best?
Yeah, a great question, but I don't have the answer. They explore all of the 3 categories per patient, per blood unit, and per transfusion episodes. But really, I don't know what is the more accurate or the best.
Doug, do you have a question?
Yes, hi. Thanks, Rafi. That was nice. I was just wondering if you why you think that the incidence of TACO was or the prevalence was so much higher with platelets compared to, say, red cells or plasma.
Yeah, very nice question. They mention it in the article, but unfortunately, I don't know exactly what their comment was. I'm not sure, but I will look back to it.
Great, thank you. I was wondering if it might be the rate of transfusion, since platelets are often, I think, given fairly rapidly relative to red cells. But I was just curious. Thank you.
Thank you so much.
If no one else has a question, I can ask one. So, Rafi, I often find like we're in the lab most of the time, and we're not necessarily the ones prescribing the transfusions. And within my center, at least, we're like we have a high volume of transfusion practice. So I'm just wondering your thoughts on what practical things that we can actually do within the lab, or processes we can put in place in order to support best transfusion practices when we're not going to be the ones to write the orders for the transfusion or submit orders on the the EMR.
Yeah, I think nice question. Thank you. I think by discussing with the clinician and the education for the nurses and for example, TACO incidents like this topic and others, by education and by communication with the clinician. Yeah, thank you.
Thanks. Does anybody have any other questions? Doug, go ahead.
Well, do we have another presentation, or can I ask you?
No, you can go.
I guess I'm just wondering how we can better educate physicians, particularly, I don't know, shouldn't necessarily point fingers, but in the emergency department where patients are sometimes transfused more than they need, let's say, in a fairly short time frame. And I guess I just wonder if we shouldn't be doing more to educate physicians around TACO and things like risk assessment and so forth. That's a general thing.
Yeah, thank you so much.
Yeah.
Yeah, nice win. Thank you so much.
Any other questions or comments? Oh, someone coming out.
Yeah, I think as well the strategy of giving one unit at a time. We can control the after negotiation with the clinician, we can give one at a time for non-bleeding patients.
Yeah, and I think like over the years we've had slightly different policies that obviously we have lots of different centers represented here. But the transition from paper-based ordering to the electronic medical record has been maybe helpful in a bit for us because we can program in, auto pop-ups for the clinicians if the hemoglobin is above a certain amount or if they order more than one unit. But I also know that providers can get annoyed by these pop-ups in the case that it's actually necessary. And then, it is hard for us to know in the lab. They can check, bleeding, and then those pop-ups I don't think ever come up. So as long as the patient's bleeding, we usually don't say too much about it. But there's a big difference between a hemorrhage, like a massive hemorrhage sort of type of bleeding, and the patient's had a tiny bit of bleeding and they're getting transfused. So I see Claire has a question.
Okay, sorry. I couldn't find the unmute button. A lot of people like to use that on me. It was a really great presentation. I'm a transfusion nurse clinician here at BC Children's and Women's Hospital. And what we encounter a lot is push for faster infusion rates, which kind of contraindicated if when we're thinking about transfusion overload, especially with wanting to reduce the amount of time patients have to spend in a clinic, or from the perspective of families not wanting to be here all day, and also from turnover time for chairs in clinics, as in we need people to move through faster. And often people say, well, these are not high-risk patients. They may not have comorbidities. And I wonder if you found it when you were looking, if TACO only occurs in patients with comorbidities. It may not have been exactly what you were looking at.
Thank you for the great question. It can happen without a real comorbidity. If the transfusion with a very high rate, it can happen, or a very huge amount of fluid giving, it can happen. Yeah, thank you so much.
Thank you.
You're welcome.
Any other questions from the crowd?
This is Gwen. I have one, and darned if I can find the hand up sign, but just a question for the group. Has anybody shown or knowledge translated or knowledge disseminated the scoring systems to their, especially emergency room staff from any of the health authorities?
I don't believe we have, Gwen, but
yeah, it strikes me that Emerge Docs use scoring systems all the time, DVTs. That might be a way to key in on TACO risk to this group that I agree are prone to being transfused very quickly. But if we could sort of give them this tool and say, before you transfuse or before you decide on the transfusion rate, are you aware of this scoring system?
Mhm.
Doug, maybe PBCO could help us with that in terms of a teaching tool.
Yeah, for sure. But actually, that's kind of what I was getting at, Gwen, with my earlier comments. And I think Claire also alluded to the fact that there's pressures within the healthcare system to get patients through quickly. And that was one of the reasons I kind of pointed the finger at the emergency department, because I think sometimes transfusion is prescribed. This is obviously just I guess speculation just on a little bit of experience, but I think sometimes patients are over transfused in emergency. They're transfused too quickly and maybe given more than one unit, as Rafi suggested. Just to get them out of the emergency department, right? To avoid hospitalization or whatever.
Yeah, for sure. I mean, and some patients maybe could, if they've been in Emerge for 15 hours already, they also probably want their transfusion to be quick. And for some patients, that's entirely appropriate. But it's just that I don't think anybody's doing a risk assessment. They're just,
Yes.
They always give the platelets over 20 minutes. They always give the blood over an hour. They just, individual clinicians, I think, develop their internal protocols.
Yes.
And it would be great if we could encourage them to actually do a risk assessment, as they do for so many other conditions.
Mm-hmm. Yeah. Yeah, and I think it's not only pressures on bed occupancy, let's say in Emerge, but also patients who don't want to stay. They don't want to be admitted to hospital or whatever, and the most expedient way of they're pushing for transfusion too in some cases, I think. So anyhow, emergency is a good place to start.
Yeah, or as Matt's suggesting in the chat too, or like alternatives to transfusion, like iron for patients who are chronically iron deficient anemic. Any more questions or comments? No? Okay, well, we'll let you go a little bit early, and please do copy that link to do the evaluation. It will be very helpful for us. And we don't generally have the transfusion rounds over the summer. However, we do have some potential other prospective trainees that might be better scheduled like throughout the summer as well, to make sure that we can get them in before applications and things like that. So stay tuned there, and have a great rest of June.